Okay, pediatric tachycardia with a pulse. You're going to come in as an ALS provider, so you have to manage and take control of the scene. You're going to maintain that your team members, you're working in crew resource management, using players and patients or personnel in the right spots, and that means that you're the guider, you're the leader. So you want to make sure everyone's taking care of the airway with BLS management. You want to make sure that everyone's doing chest compressions according to the appropriate rate, depth, and quality, ensuring that they're checking pulses with compressions. You can monitor adequate compressions with artificial ventilations with your end tidal, and that should be above 12. So we want to see that in around in the 20s. You're gonna make sure that you have people put on your EKG, pulse oximetry, and then try to establish IV access. If you're the only ALS member, then you're the one that's supposed to get that IV access. You can delegate other people to put on other leads or EKG or even the pads, the hands-free defibrillation pacing pads, multifunction pads. As you look at your EKG, you're the only one that can interpret this as the ALS provider. EMTs, they can help with that, but they're not there to really scrutinize the rules and criteria for evaluating rhythm recognition. They have a better sense of more like dead reckoning, just analyzing a picture, but they can't analyze it through rules. So you need to be able to do that. Now let's go over the narrow complex. So narrow complex, it could be a pediatric sinus tachycardia. Their rates are much faster than normal, so it's above 160. It can hit into the 200s, but you'll see R to R fluctuation. I mean, the intervals between each R to R complex will tend to change. You will see it spike and drop in the patient's position or their emotional state. And this also correlates potentially with their history, as there may be some fluid um imbalance where they're vomiting or just having large amounts of diarrhea and the like, or it could be related to emotional state. It could be related to pain tolerance. It could be driven uh, somewhere else other than this increased automaticity that occurs in the supraventricular cardio realm. So search for the causes if you think that this may not be an SVT. Now, SVT usually is dead on all the time. The R to R intervals don't fluctuate much, and it doesn't change if the patient is sleeping, resting, anxious. There isn't other possible causes such as fever or pain in the result. This is just dead on. Heart rate's just extremely fast. You may have a history here where the patient has had some type of previous examination by a cardiologist and they have this type of tachyarrhythmia. So it's a narrow complex supraventricular tachycardia. These rates are dead on. They do not change, and we can consider vagal maneuvers. This might be ice compress over the eyes, maybe some kind of carotid sinus massage. You may try to stimulate by placing a rectal temperature as you're trying to rule out that it's other possible causes. This may cause the vagal tone when they kind of bear down, and that might be a method of vagal maneuvers. Consider your IVIO axis as you delegated that at the top, or if you're the one that was doing it, you're delegating other things why you could establish this IV. You can consider giving a fluid bolus 10 to 20 cc's per kilo if you think there was some kind of volume depletion before you decide to see if the fluid will change and before you decide to give your adenosine. Now, adenosine, remember, you need to give it in a large axis, a large IV peripheral axis, and it's going to have to be flushed in with about 10 cc's or so right behind that with another little volume push opening that IV bag. And so you're going to be giving zero point 0.1 milligrams per kilogram first dose, max up to 6. And then you're going to give zero point 0.2 milligrams per kilogram, max dose up to 12 to see if you have conversion. Remember, when you're giving this, you're going to hit record on your EKG to capture any changes that occur when adenosine is being given and flushed in, and then be sure to turn your printer off so that you don't waste paper. You can also think about synchronized cardioversion, and you may want to give some type of sedation. That would be your Versed. You're giving 2 milligrams in cases of intranasal or IM. In cases of seizure, that might be loosely applied here. If we are using for sedation, you may think about zero point 0.1 milligrams per kilogram to be given, but we're going to use synchronized cardioversion and we'll start off at a lower, so zero point 0.5 to 1 joule per kilo, and subsequent increasing up to 2 joules, and then we'll continue to go up until 10 joules per kilo. Remember, if you are trying to, you don't have no IV access and you're trying to use the synchronized cardioversion, continue to try to get at least an IV access. Here's the caveat. Please do not use, again, do not use up all the IV and IO sites. If the patient has poor access, let's consider giving some access and using some, giving them an opportunity at the hospital to use an IO or IV access route because they're going to need to establish something there. So if you're a novice provider, let's go ahead and get on the horn and communicate early and early transport this patient. Now, when it becomes wide and you consider that it's a ventricular in origin, then use your rules, and we're going to go right down to whether it's stable, then we go to synchronized cardioversion because we need to get that patient out of that rhythm, or they'll deteriorate to a pulseless, and then we're going to have to do chest compressions, and it's just chasing this rhythm now. So if you think it's ventricular in origin, go ahead and synchronize cardioversion again. 1 joule per kilo and then 2 joule per kilo and all the way up until we get to the 10 joule per kilo. In the meantime, don't forget these boxes up here. We got to get that IV. You got to get that oxygen on. You got to have that 12 lead. You have to get those other routes secured and consider the airway. If it is a rhythm that's kind of you're not sure if it's ventricular or if it's supraventricular, but the patient is stable, you might consider giving adenosine. Again, if it is VTAC, you know that it is, and they're not unstable here, then you can go ahead and give you amiodarone. We're giving 5 milligrams per kilogram. You can run that in over 30 minutes. It kind of makes it a little easier. And then you can think about procainamide, 15 milligrams per kilogram, same thing over the 30 minutes. So go ahead and practice. Bring out your ECLS book and consider, a patient. Let's say I'll give you a patient that's, let's say they're 3 years old. We'll make them 15 kilograms.